how are we going to manage a case of slipped capitofemoral epiphysis? Okay, so if there is a mild slip means that you'll go for two views. Okay, one is anteroposterior view, other one is lateral view. In anteroposterior view, if it is less than one third of the visibility of the epiphysis. Okay, so if in case it's width, okay, one third of the width of epiphysis. So in the AP view, if you can see that there is less than one third of the width of the epiphysis is basically slipped, or in the lateral view you can see less than 20-degree tilt, then you can go for reduction with Austin Moore spin under fluorescence control. Okay, reduction Austin Moore spin, okay, with fluorescence control. But if in case it's a major slip, so in the case of major slip, what we'll do is not moderate, okay, major slip. So in the case of major slip, what we'll do is, in the AP view, what is the major slip category is 1/3 to 2/3 width. 1/3 to 2/3 width is the major slip, and in the case of severe slip, it is more than 2/3. Okay, and in lateral view, you will see that around 20 to 40-degree tilt, and in severe slip in the lateral view, you will see more than 40-degree tilt. So if this is the case, in the case of severe slip, you have to go for osteotomy, no doubt. Osteotomy, and then you just fix epiphysiodesis. It is known as epiphysiodesis, surgically fusing of the epiphysis, right? But in the case of major slip, if in case you think that this is not going to be treated with the case of close reduction with percutaneous pinning, then you have to go for open reduction, and then you have to go for osteotomy. The method by which we go for open reduction and osteotomy is known as Dunn's method, D-U-N-N-S, Dunn's method. Okay, this is often being asked. Okay, Dunn's method. And one more thing I would like to add upon, in the case of your diagnosis of SCFE, I missed one point. I told you about cleans line, and I told you about 301 sign, right? 301 sign. But I did not tell you about the disruption of the Shenton's line. So disruption of Shenton's line is seen Shenton, okay, Shenton's line. So disruption of Shenton's line is seen in various other conditions like posterior dislocation of hip, anterior dislocation of hip. It is seen in the case of central dislocation of hip. It is seen in the case of DDH. It's seen in the case of SCFE. So there are a lot of causes of disruption of the Shenton's line. Okay. So in a nutshell, just understand that SCFE is a misnomer. The neck goes superolaterally. I already told you that it goes superiorly. Because of the pull of the muscles and towards the lateral aspect. Okay, so it's a type 1 Salter-Harris classification through the hypertrophic zone of the growth plate. Okay, so head, it sits inside the epiphysis. It sits inside, as I have already told you, and I already told you that the left hip is much more common than the right hip. About the case presentation, we have already talked about the case presentation also. So I like just to go to some of the things that is written in Maheshwari. So let's look into the things written in Maheshwari. See, so I already told you about the pubertal age group, 12 to 14 years, male, commonly presenting, okay, and fatty and sexually underdeveloped males. I already told you. Why tall? Because there is a growth hormone spot, but there is not a sex hormone spot. Okay, tall, sexually normal children. It's written sexually normal children. By looking, it's a sexually normal children, but there can be history of micro penis, or there can be history of they can be actually, you can actually examine gynecomastia or micro penis in those individuals. Coxa vara deformity is seen, as I've already told you, difficulty in abduction and internal rotation, right? And more common to boys. This is also already talked about. There might be a history of trauma. Why trauma? Because trauma induced fracture may be there, or they can just be due to weight bearing, obese person, too much weight bearing to the weak growth plate, there can be a fracture. Okay, and you need to remember one more thing, that the leg is found to be externally rotated and 1 to 2 centimeters short. I already told you, difficulty in abduction and external rotation. If there is difficulty in abduction and external rotation, what will be the presentation? Difficulty in abduction and sorry, it's difficulty in abduction and internal rotation. Okay, difficulty in abduction and internal rotation, all the coxa vara deformity. So the patient will present with adduction and external rotation, right? So limitation of the hip movements is characterized, there is limited abduction and internal rotation, right, with a corresponding increase in the adduction and external rotation. When the hip is flexed, the knee goes towards the ipsilateral axilla. Normally it should go towards the contralateral axilla, okay, but this goes towards the ipsilateral axilla. Okay, this is one test that you can perform. Okay, Trendelenburg sign can be seen. Trendelenburg sign can be seen in all unilateral DDH, coxa vara deformity, SCFE. Okay, remember Trendelenburg gate. It is seen in all the coxa vara deformity. Okay, and you can see 301 sign, cleans line, as I already told you. And on the lateral view, I told you about the angles, right? Tilt. So acute sleep, gradual sleep, and unaffected size. See here. So if it is, you can go for a close reduction and pinning, right? And if in case it's a moderate sleep or a major sleep, AP angle view 1/3 to 2/3, as I already discussed, 1/3 to 2/3. You can go for what can you go for? Yes, you can go for either, you have to go for osteotomy by Dunn's method, or you can go for close reduction, right? By and pinning. Okay. And if it is a severe sleep, you have to go for osteotomy. Okay, this was all about SCFE. So let's revise once again. SCFE in a nutshell. SCFE, more commonly seen in boys. SCFE, growth hormone excess and your sex hormone less. Salter-Harris type 1 classification through the hypertrophic layer of the growth plate. SCFE related to hypogonadism, hypothyroidism, and all the things, gynecomastia, hyperprolactinemia, endocrinal problems, right? Diagnosis, Shenton's line disrupted, cleans line, 301 sign. Okay. Treatment, mild, major or moderate, and severe. Okay. How would you actually treat the condition? You'll go for osteotomy by Dunn's method. Okay, thank you.